Classifications. Classification. There are several methods of the clinical classifying periodontal health. Mahler classification for mobility. Class 0 normal tooth mobility. Expect some give to the tooth due to the PDL. Class 1 slightly more mobility than normal. Class 2 moderate mobility below 1 mm. Class 3 severe mobility above 1 mm. Vertical mobility into tooth socket impossible. Harm classification. Furcation. Class 0 no furcation involvement. Class 1 below 3 mm horizontal furcation involvement. Class 2 to 3 mm horizontal furcation involvement. Class 3 through and through furcation involvement. The probe can be it through. Harm classification uses a Naber's probe for measuring. Each section represents 3 mm. Ability to dip probe into furcation indicates furcation involvement. Naber's probe, William probe types. Glickman classification. Furcation. Class 1 pocket formation into fluid but not enough to expose furcation. Incipient. Glickman classification. Furcation. Class 2 pocket formation into the furca, also known as a cul-de-sac furcation involvement. Class 3 through and through furcation. Class 4 through and through furcation. It displays a clear space that can be seen through. Alveolar bone loss. The type distance from the alveolar crest is 2 mm. The line connecting the alveolar crest should usually be parallel to the connecting CEZs. Bone height is alveolar bust. The typical distance from the alveolar crest 2 mm. The line connecting the alveolar crest should usually be parallel to the line connecting CEZs. Bone height is best measured with a bite-wing radiograph. Horizontal bone loss occurs when bone loss is still parallel to the line connecting the EZs. Vertical and angular occurs when bone loss is not parallel to CEZ line and is classified by the number of bony whorls remaining. Infrabony defects. 1 whorl hemisectoral shape whorl, 2 whorl crater shape. Most common loss of intersector bone between 2 teeth, buccal and lingual whorls remain. 3 whorl trough shape. 4 whorl bone remains around the circumference. Terms exclusively for ejection socket. 1 whorl, 2 whorl, 3 whorl vertical bone loss. INBDE pro-tip terms for infrabony defects are very popular on INBDE. Make sure you know them. Miller classification recession. Miller classification indicates the probability of regaining root coverage through the connective tissue graft procedure. Note that the Miller classification for mobility is a separate system. Class 1 gingival recession does not reach mucogingival junction. Loss of interdental bone or soft tissue not present. 100 likelihood of full coverage via graft since no interdental bone was lost. Class 2 gingival recession reaches or gets beyond mucogingival junction. Loss for interdental bone or soft tissue not present. 100 likelihood of full coverage via graft since no interdental bone was lost. Class 3 gingival recession reaches or gets beyond mucosal gingival junction, and loss of the interdental bone and soft tissue or root coverage prevented by tooth malpositioning. Partial likelihood of coverage via graft. Class 4 gingival recession reaches or gets beyond mucosal gingival junction, loss of interdental bone or soft tissue or root. Gingivitis and classifications. Gingivitis can be identified by the 3 C's: color, contour, and consistency. Color rather from increased blood flow, contour inflammatory exudate, and edema. Fibrosis of gingivitis is chronic plaque-induced gingival disease. Plaque-induced gingival disease is a common type of gingival disease that is caused by the interaction between plaque bacteria and host immune cells, modified influenced by medications, calcium channel blockers, dilantin, and cyclosporin associated with drug-induced gingival enlargement, oral contraceptives, systemic factors, endocrine diabetes, pregnancy, malnutrition. Non-plaque-induced gingival disease. Non-plaque-induced gingival disease is a less common type and can be a response to allergies, restoration materials, food, germ, factitious, accidental, iatrogenic damage from dentist, infection material, viral, fungal, hereditary gingival fibromatosis from non-hemorrhagic tissue. Periodontal disease. A traditional periodontal disease is classified using 3 different terms: distribution, severity, and type. Distribution describes how many sides are affected. Each tooth has 6 sides: distofacial, mid-facial, mesial-facial, lingual, mid-lingual, distal-lingual. Therefore, each patient's total amount of sides is a number of total 60. Generalized, more than 30% of sides. Localized, smaller than 30% of sides. Severity, slight CLAL critical attachment loss is 1-2 mm. Moderate CAL is 3-4 mm. Severe CAL more than 5 mm. Type chronic periodontitis, slow progressive bone destruction proportional to amount of microbial deposits. Black patient is clinically unhealthy. Is smoker, diabetic, modified by systemic issues, tends to be older in age. Aggressive periodontitis, fast bone destruction not proportional to amount of microbial deposits. Patient is clinically healthy. Molar incisure pattern in local version, where deeper pockets are only seen in molars and or incisures. Familial aggregation tends to be of young age. Necrotizing, either a nip, acute, necrotizing, ulcerative gingivitis, periodontitis, pseudomembrane fever, fatigue, breath, blunted papillae, specific to individual who smoke, have stress, smoking, and immunosuppression are predisposed. Periodontitis can therefore be classified by the distribution, severity, type, disease, respectively. It's a localized, moderate chronic periodontitis. It's generalized like aggressive periodontitis. Epidemiology. The following are the few common facts on IMBD. Most common up to least common periodontitis: chronic, localized, aggressive, general aggressive, refractory. Most prevalent group to get periodontitis are Mexican Americans, non-Hispanic Black Americans, and those who regularly smoke. New AAP periodontal classification.